Hi everyone, welcome to your online lecture for Pathophysiology 2. In today's lecture, I'm going to be discussing the acute effects of atherosclerosis and hypertension. And so it is important that you would have first gone through the lecture that was posted on atherosclerosis and hypertension, going into detail about what these conditions, what these states are before you go through today's lecture. First, we're going to talk about the concept of hemostasis. Hemostasis is just the stoppage or cessation, we can say, of bleeding. And this occurs because of the formation of blood clots at a site where there is vascular injury. And this is going to allow our blood vessels to maintain a relatively stable state of blood volume, blood pressure, as well as blood flow. So if it wasn't for the formation of a clot, then the body would go further and further away from homeostasis. The general sequence of events in hemostasis includes 1, vascular injury that's going to lead to this transient arterial vasoconstriction. That's a natural response. And the purpose of the vasoconstriction is to limit blood flow to that affected site, which ultimately limits blood loss. Second, we're looking at platelet plug formation. This is where platelet adherence occurs, where platelets become sticky and they can form a plug in the area of injury. This involves various chemicals. Third, we have clot formation. This is the coagulation system. The coagulation system is going to be activated, which is going to form a fibrin clot or like a net that will prevent further bleeding. And this process allows for limited blood loss, as mentioned earlier, but it also allows for healing to occur. I'm sure you've all had a cut in the past that has clotted, and then you go ahead and you maybe not even realize you're doing it, but you pick off that clot, and then really what you're doing is you're taking off that clot. And that's going to allow for bleeding to occur again. And so you're just making your body do the same job again and again every time you remove that clot, and that increases your chance of infection and could potentially worsen the injury site, making repair maybe longer and possibly more difficult as well. Now let's have a look at a few very important definitions. And we've talked about these in the past, so some of this is review, but very important. Let's start with a thrombus. A thrombus is a blood clot that remains attached to a blood vessel. And we've talked about that many times before, that if you have clotted blood in an area, such as shown in this image here, it's called a thrombus. And a thrombus can form anywhere throughout our vascular system. Where this can become a concern is if it gets large enough that it completely blocks the lumen, or if it dislodges and travels downstream. Thrombosis is a state of clot formation. This is where we have within the blood vessel intravascular activation of the coagulation cascade. Remember, we've talked about the coagulation pathways in Altered Physiology 1, but what's interesting is we get thrombosis, this activation of the coagulation cascade, occurring even without damage to the vessel wall. So we normally think if we have a bleed, then we're going to form a clot. But what we have occurring here is a clot formation without actual damage or rupturing to the vessel wall from, say, some external injury. Next up is a thromboembolus. We've talked about the term embolus many times already, so I'm just going to highlight it here. I reiterated during our in-class lecture that an embolus is going to be some substance that's traveling in the blood that shouldn't be there, that could, as it moves downstream, get blocked or jammed somewhere, causing ischemia and possibly leading to an infarction. But if it is a clot that dislodges and travels in the bloodstream, it can more appropriately get the name thromboembolism and embolus. And all that means is that the embolus, the substance moving in the blood, is a clot. Because we know, or you should recall, that an embolus can be really anything that's in the blood that's large enough that it could get lodged downstream. It could be a piece of foreign material. It could be air. It could be a clump of cancer cells, for example. So this just tells us that the embolus, that traveling substance, is a clot. Thrombophlebitis. Itis, you should know, means inflammation. Phleb has to do with the veins. And thrombo has to do with a clot. So if we put what we know about these terms together, it is the state of thrombosis, so forming a clot, plus inflammation in the veins. And we'll learn more about this later, but a clot forming in your veins can be dangerous because if it dislodges, it can travel back towards your heart and make its way to your lungs, where it can cause a pulmonary embolism. So we know that clots can form even in the absence of bleeding, and that the clot can block or occlude a blood vessel, so causing ischemia, reducing blood moving through that artery, which could cause hypoxia or an infarction to an organ or tissue downstream. So we know why thrombus formation is a big deal, because of it causing ischemia, which could lead to hypoxia, which could eventually lead to an infarction or tissue death. But we're going to look at this in a little bit more detail throughout today's lecture. On this slide, we have various different causes of arterial thrombosis. So what this is saying is the formation of a clot, the activation of the clotting system within arteries. Why does it occur? Well, I'm going to jump right down to something that we've already talked about during our in-class lecture, and that's atherosclerosis, which is the most common cause of clot formation within our arteries. And we know that the reason that the clot forms, based on our in-class discussions, is because the endothelial tissue of the vessel has become damaged, and an injury will promote clot formation, attracting platelets to the area. But that's not the only cause, even though it is the most common. We have other causes as well, starting here with blood stasis. Blood that is not moving at its normal speed, or blood that's maybe pooling, this is prone to clot formation. In other words, it's prone to activating platelets. So we can say that if blood stays where it is for too long, or if it's moving very turbulently, you can think of that as meaning violently through a vessel, it's prone to activating platelets and therefore forming a clot. So to give you a real-life example, a long period of inactivity, there are many examples, but one example includes people that are sedentary and sit for very long periods. For example, people that are very sedentary and then they get onto a plane and they're sitting on a plane for many, many hours. That inactivity of the muscles in the legs means that the blood is not going to be returning to the heart at its normal speed, because remember, muscles contribute to the movement of venous blood in our body, helping to return it to the heart. And so this inactivity, where blood is going to be sitting in veins longer than it should be, is prone to the development of a clot. So people that are flying are encouraged to keep their legs moving, even just pointing and flexion and extension of at the ankle can cause those muscles to contract to help return blood to the heart and reduce the incidence of blood clot formation. Turbulent or violent blood flow. These are two examples. Aneurysms, which we'll talk about soon, is where you have ballooning of a vessel. And when it balloons, the blood that is moving through it is more likely to sort of wish-wash against the ballooned out areas, moving more violently. And then atrial fibrillation is an abnormal heart rhythm that's characterized by very fast and irregular beating of the atrial chambers, those top chambers of the heart. And this irregularity can cause blood to sort of move more turbulently, and sometimes not enough blood leaves the heart, and it can pool within some of the chambers. And so whether it's turbulent blood flow or blood that's sort of pooling in an area, it increases the risk of platelet activation. Thrombi can also form due to endothelial wall infections. And so what I mean by that is the inner lining of the heart that's lined by endothelial tissue, which continues into the valves of the heart, can become infected with bacteria. And we call that bacterial endocarditis. And when bacteria is present, it can be present in these clumps on the valves, and we call those vegetations. And the presence of these vegetations can promote thrombus formation. And those, like any other clot that can be formed, can travel from the area if it dislodges and go elsewhere. But the problem with these occurring in the heart is that the heart can actually pump these emboli, or it could be from the thrombus or the bacteria, but pump it throughout the body as an embolus. And rheumatic fever, this is a condition that can inflame or make the heart, joints, brain, and skin swell. Rheumatic fever is thought to be an immune response that can occur from an earlier infection. So in rare cases, somebody that has strep throat, and rare cases for sure, can develop rheumatic fever. And this inflammation of the heart, in this case, can promote the development of clots, leading to potential problems down the road. If somebody is suffering from inflammation of their vessels, that can be termed generally as vasculitis, so inflammation of vessels that are part of the vascular system. Now, if it's specific to the arteries, we can call it arteriitis. So let's say somebody has a plaque that's developed and our body thinks it's an injured site within the vessel, so this immune response happens, and we know immune responses involve inflammation, as we talked about a lot last term, but this can promote the formation of clots. And then finally, shock is a cause of arteriothrombosis, but shock is a systemic problem, so it happens all throughout the body rather than just in one particular area. And if somebody experiences shock, which is a very serious condition that can occur because there's been a sudden drop in blood flow throughout the body, and there's many different causes of shock that we don't have to worry about right now, except that a blood infection called septicemia, emia is blood, septic implies infection, this can lead to widespread clot formation. You may have heard of the term DIC, or disseminated intravascular coagulation, where you can get clotting occurring all throughout the body, which can cause problems all throughout the different organs in the body. Okay, so we're going to talk about an embolus in a bit more detail, but now you have an idea already of what it is. So embolism is really the state of embolus formation and what can occur from it. So if somebody has an embolus and it travels to an area in the body and blocks blood flow to that area, that is called an embolism. And a very common one that don't worry about making note of right now is one that I mentioned earlier, where if somebody has a clot formation in the veins in their leg and it dislodges and travels all the way back to the heart and then is pumped to the lungs, it can actually block the movement of blood through the lungs, and that's called an embolism, but because it affects the lungs, it's called a pulmonary embolism. So we know an embolus then is some form of matter, we can call it a bolus of matter that is moving throughout the bloodstream, and as blood vessels get smaller, it can block them. So it could be one of many different things that make up the embolus. We've talked about a dislodged thrombus before. That really is the most common, and here's the condition that I spoke about. A vein in your leg, a deep vein, can form a clot called a deep vein thrombosis, or a DVT for short, that can be sent to the lungs. In addition, if somebody has atrial fibrillation, a clot can be thrown from the heart, out of the heart, to tissues. And I spoke about if the lungs are affected, it's pulmonary embolism, or if the clot is the cause of pulmonary thromboembolism. An embolus can also be made up of fat. And although there are different methods by which fat can get into our bloodstream, one of the more common methods is if somebody has had a fracture of a bone, so for example, of their femur, this can cause, because of the break, some of the fatty yellow marrow, because remember that yellow bone marrow is going to be made up of fat, can get into the bloodstream and block vessels. And air embolism can also occur. This is more commonly occurring during IV therapy, so intravenous therapy, where you can accidentally introduce air into a vein. But it can also occur if somebody has damage, like say a punctured lung, where air that's in the lungs can get into blood vessels. Women that are pregnant that have amniotic fluid within the uterus, this could enter maternal circulation and be a problem because the consistency of amniotic fluid is different than our blood. Bacteria we've already talked about. We've talked about it from the state of vegetations that can promote clot formation, but bacteria can enter the blood in clumps and act as an embolus. Some foreign substance that's injected into the body, and cancer cells that have clumped together, maybe broken off of a tumor and entered into the blood, can also cause an embolism. But in any case, the effect can be the same. All right, because we know atherosclerosis is the most common cause of thrombus formation, let's look at some of the acute effects of atherosclerosis, where we have the development of a clot and there is then a risk of a myocardial infarction. We know, based on our in-class lecture, that an atherosclerotic plaque is going to have this lipid-rich core and this thin fibrous cap. So here's the lipid-rich core and then this fibrous cap. Now this fibrous cap is susceptible to tearing. There could be, now why would it tear? There could be some sort of shear force that's applied to it, inflammation. There's many different potential reasons, but in any case, rupturing of the plaque could occur. And as soon as we have rupturing of the plaque, now we have an injury. And we have an injury that our body is going to respond with inflammation, with the release of cytokines, with the release of platelets, with the release of clotting factors. And we're also going to see vasoconstriction occurring. The thrombus will develop in that area over the lesion, which we can see occurring here. And this thrombus plus vasoconstriction, that's a naturally occurring event when there's injury, is going to limit blood flow through that vessel. So we've got not much room for blood to move through the vessel. And if we're talking about the heart like we are in this example, if this is happening in the coronary arteries, we're reducing blood flow to heart muscle. And we call that coronary blood flow is reduced through the coronary arteries. And what this can lead to is what we introduced last term is angina, or last class, angina. That's chest pain. And it can also cause a myocardial infarction, which is a heart attack. And that's all dependent on how little blood flow, or how much blood flow we could say, is getting through that vessel to the heart wall. Now, what's interesting is some people can have this atherosclerosis present within their vessels, let's say of the coronary arteries. However, a clot that forms might not be a problem. The body might be able to break it up with antiplatelet factors. Break it up so that we don't have as much occlusion of the vessel. And when this happens, it can temporarily cause a bit of an issue and then go away. But in other cases, the clot can remain there and can even get bigger, further occluding that vessel. Now, this is a very unstable situation, and we're going to talk about unstable angina in an upcoming slide. Okay, so let's carry on a little bit with some repeat. Chronic formation of atherosclerotic plaques are quite common. And this state, this chronic state, is really considered a stable situation. It's a stable plaque. It can also lead to stable angina. And I introduced this in class as being a type of angina that is predictable. So stable angina is predictable. And you could have somebody that, let's say, doesn't get any chest pain, angina is chest pain, doesn't get any chest pain, but then as soon as they start to exercise, and now all of a sudden the demand of how much blood needs to flow through those coronary arteries causes them to have some chest pain because we can't get enough blood through the coronary arteries under that exerted state. And so it can cause chest pain, again, that is predictable. We'll talk later about unstable angina, which is much more concerning. Now, why is somebody experiencing chest pain? Well, if they have atherosclerosis and they have narrowed vessels, some blood can get through, but if all of a sudden the demand for blood to the heart muscle increases, we can't get enough blood through here to accommodate the needs, the metabolic needs of the heart muscle. And so the response is chest pain. So it's really due to ischemia to the heart muscle. Now, if there's a situation, as mentioned already on the last slide, where maybe there's shear forces or inflammation that occurs, we can go from this stable plaque state to an unstable plaque. And an unstable plaque can rupture. And what this leads to is an injury response. And when we know there's injury, there's going to be inflammation. We know we're going to be producing substances that promote vasoconstriction. We're going to activate and recruit platelets to that site. Thrombin is going to be produced, which promotes clot formation. And now we're producing a clot in the coronary arteries at the site of the plaque. And that brings us back to the image that we've looked at many times already, which is where we have this plaque formation and it has ruptured. And because it's ruptured, it promotes an inflammatory response. And now we have the formation of a thrombus. This is now, we already know, an unstable plaque, but this can lead to unstable angina, which is much more concerning. But now that we've reduced the lumen size, we're going to have a reduction in the amount of oxygen that can actually get through that narrowed artery. And if somebody's in a state where they need even more oxygen because maybe they're exercising or maybe their sympathetic nervous system is activated where their heart rate goes up in response to something, it can lead to what's called acute coronary syndrome. Acute coronary syndrome can have two really main effects. One, it could lead to myocardial ischemia. Remember, myocardial is referring to the heart cells, so the muscle cells, and ischemia is a reduction in blood flow. Now, this state of myocardial ischemia, it's going to vary the effects depending on the situation and the person. But when we have a reduction in blood flow to any cells, in this case the heart, it can lead to hypoxia of those heart cells. They're not getting enough oxygen. And depending on how long, it can lead to cell injury. This effect is going to lead to that angina that I spoke about earlier. So it's going to cause some chest pain. It's going to make somebody feel uncomfortable. They might start sweating, feeling nauseous. They may vomit. And in more serious situations, and depending on the overall health of that person, they could even lose consciousness. So myocardial ischemia is a major red flag that needs to be dealt with, because if it's not, then we're in a state of infarction, tissue death. So myocardial infarction, if you don't know already, you can put in brackets that this is a heart attack where cardiac muscle is showing evidence of death. Now, although I will talk more about unstable angina soon, I just wanted to state now, part of this is reiteration, that stable angina is predictable chest pain. And it usually comes on because somebody is exerting themselves and all of a sudden the heart muscle needs more oxygen and it can't get it. Whereas unstable angina is unpredictable chest pain. And this is the type of chest pain that will occur even at rest. Now let's define some important terms, many of which we've already looked at, but we'll give you now a more concise definition. The first term is ischemia. Ischemia we know is a reduction of blood supply to tissue, and that means that less blood is moving through an artery to reach the tissue that it's destined to go to. And the reason for the ischemia can be multiple causes. It could be that there is a plaque formation, or maybe there is a clot formation, anything that impedes blood flow. Next up is hypoxia. Hypoxia is when a cell or group of cells that make up a tissue or an organ is not getting enough oxygen for normal processes. Hypo means below, and oxia is referring to oxygen. So this is lower oxygen than is normal to a cell or tissues. Hypoxemia. Emia refers to the blood, so this is low amounts of oxygen in the blood. And so even if our blood vessels are normal and there's no issues with the blood vessels, if we don't have enough oxygen in the blood, then the tissues are not going to get the amount of blood flow they need for proper function. The term infarction. This refers to tissue death, which is oftentimes due to lack of oxygen reaching the tissue. Oftentimes it's because of ischemia or full blockage of a vessel. Necrosis, we talked about a lot last term, is actually cell death, where we see those pathological changes that are occurring within the cell. Angina is chest pain. Chest pain occurs because we're not getting enough blood flow to the area, and so we can say that it's due to cardiac ischemia, reduced blood flow to heart tissue. Myocardial infarction is where we're seeing cardiac injury due to not getting enough blood flow to the heart muscle. There is another more specific term called acute myocardial infarction, and this occurs very suddenly and is usually pretty serious. So it's really a sudden onset myocardial infarction. And then cardiac arrest means to stop. This is where the heart stops pumping suddenly, and so blood flow throughout the body is going to stop entirely. So this is where entire pumping stops. That is different. Cardiac arrest is different than myocardial infarction. A myocardial infarction is going to impact one area of the heart that didn't get the blood supply it needs, meaning that muscle that is not getting enough blood supply, that muscle of the heart, isn't going to be able to efficiently pump blood out of the heart. But maybe the other chambers are working fine. But with cardiac arrest, you have complete stoppage of heart pumping. I'm going to talk about transient myocardial ischemia now. Transient meaning lasting only for a short time. But people that have transient myocardial ischemia are at increased risk of experiencing unstable angina, talked about more on our next slide. Prinzmetal angina, which you should make note of, is where a vessel can start to spasm in the heart. And when it spasms, it leads to this unpredictable chest pain where it comes out of nowhere, called Prinzmetal angina. Transient myocardial ischemia can also lead to something called silent ischemia, which, just as the name suggests, is a type of ischemia that doesn't have any symptoms. So it's ischemia that doesn't cause any very detectable or obvious symptoms. So the person isn't complaining of pain, but ischemia is still occurring. One of the reasons why it can come and go, the ischemia, is because coronary arteries, more so with healthy ones, they have this ability to dilate in order to increase the flow of oxygenated blood to the myocardium. And so with transient myocardial ischemia, perfusion is restored before there is permanent damage to the heart muscle. But over time, you can end up in a much worse situation. Okay, so myocardial ischemia can also be caused by other factors. So we've talked about atherosclerosis, particularly looking at a type of myocardial ischemia that can come and go. There are also other potential causes of myocardial ischemia that can occur more consistently or transiently, and that includes anemia, hypoxia, hypotension, which is low blood pressure, arrhythmias, irregular heartbeats, coronary spasms, so this is where the arteries start to spasm, which reduces blood flow through them, as well as a sudden increase in demand. So the heart muscle needs more oxygen and it's unable to get it due to existing problems, and the person will experience myocardial ischemia. Now, what causes an increase in demand? Well, it could be just that somebody's heart needs to beat faster. And if it's beating faster to put more blood out of the heart to the rest of the body to meet those needs, the heart muscle itself, just to get the energy to contract faster, is now going to need more oxygen for itself, but not able to get it. There are particular areas of the heart that are more prone to injury or a more specific injury. The pericardium, remembering that term from normal anatomy, that's the fibrous sac that really encloses your heart and the great vessels. Areas that are further away from the pericardium, the outer part, are more prone to damage. So the closer to the pericardium where the damage occurs, the less damage. The deeper, further away, the more damage. And so we have different zones that you can see here with this outer zone here that's called the zone of ischemia, closer to the pericardium. Deeper in, we have the zone of hypoxic injury, so more likely to have injury to these cells. And then we have the zone of infarction and necrosis, and this is, of course, the most serious situation. Okay, as promised, we're coming back to unstable angina. So what is it? Unstable angina, I'd like you to make note, is a form of acute coronary syndrome. Acute coronary syndrome that results in reversible myocardial ischemia. And it's important to recognize this syndrome because it really signals that the atherosclerotic plaque has ruptured and infarction could follow. So we can assume that when somebody is experiencing unstable angina that they may have had rupturing of the plaque, formation of clots, possible vessel occlusion, and vasoconstriction as a response to that injury, as we talked about before. In terms of clinical manifestations, unstable angina presents as really new onset angina. It's angina that is occurring at rest or angina that is increasing in severity or frequency. Those that are experiencing unstable angina will report maybe that they're experiencing shortness of breath, which is dyspnea. They may report that they're experiencing excessive sweating, which is diaphoresis, and feelings of anxiety. And the person will appear to be very anxious as well. Now, if the clot is not removed, that's contributing to the unstable angina, and blood flow is not able to resume within 20 minutes, then it can lead to infarction and tissue can start to die. And so somebody that has these signs and symptoms is experiencing the early stages of a heart attack and should be treated immediately to prevent damage. So how is treatment done? Well, immediately providing oxygen, because we know there's going to be an oxygen debt, aspirin, which is a blood thinner, which can help break up the clot, vasodilators that can open up the vessels, even though they are blocked. If we can open them up a little bit to allow for some more blood to move through, that can be life-saving. And then pain relief options. Depending on the circumstance, some people need bypass surgery, which is just a method of diverting blood around a narrowed or clogged part of a major artery in order to improve blood flow and therefore oxygen supply to an area of the heart. Drugs to prevent formation of clots, drugs to dissolve clots, drugs to reduce the workload of the heart. If it doesn't have to work as hard, then the tissue is not needing as much oxygen and therefore blood flow. Long term, need to get people's cholesterol levels under control, specifically looking at that LDL component as discussed in class. And the hugest component is lifestyle change. And that's going to be dietary changes in almost every case. In many cases, smoking cessation, so to stop smoking, and then exercise. So these variables not only really contribute to preventing a heart attack, they're also used to treat people that have already progressed with cardiovascular disease. This here is showing you the timeline that's approximate, just to give you an idea of progression when we're talking about a myocardial infarction. So the precipitating event, as already discussed, is that a thrombus is formed, usually due to rupturing of a plaque. And this is going to affect the flow of blood, so causing ischemia, which is reduction of blood flow, leading to hypoxia of the myocardiocytes. Within seconds, we're going to see this ischemia occurring when the thrombus forms. Within minutes, we're going to have a reduction in the heart's contractility. It's not receiving as much oxygen, so it can't make as much ATP. And so it shifts from a state of aerobic metabolism to anaerobic metabolism, which is not as efficient in the production of ATP, which is required for so many functions. Within 20 to 30 minutes, if this is not corrected for, then a myocardial infarction can ensue. Within 18 to 24 hours of a myocardial infarction, we're going to see inflammation. Within a couple of days, 2 to 4 days, necrosis. So the pathological changes within the tissue that indicate death, remember, is the definition of necrosis. Within 4 to 10 days, healing will occur. And healing it doesn't mean it's going to heal to what it was before. The heart is going to repair to the best of its ability and really remodel. But in a lot of cases, we have scar tissue formation, and scar tissue within the heart means that the heart muscle is not going to be able to contract as well as it should. When there is sudden coronary obstruction that's caused by a thrombus formation over a ruptured atherosclerotic plaque, I mentioned that acute coronary syndromes can occur. Acute coronary syndrome includes unstable angina or myocardial infarction. So let's go through this flow chart. We have that atherosclerotic plaque that partially obstructs coronary blood flow. We would call this a stable plaque, which leads to stable angina. However, if the plaque becomes unstable because it started to rupture and then a clot forms, we have acute coronary syndromes occurring. We're either going to get unstable angina or a myocardial infarction. If the ischemia is transient, it can lead to unstable angina, as already mentioned. But if for any reason there is sustained ischemia, it can lead to a myocardial infarction, leading to myocardial inflammation and necrosis. So unstable angina then is the result of what we can say is reversible myocardial ischemia. However, it is an indicator of an impending infarction, so it needs to be addressed. Myocardial infarction, on the other hand, is going to result when there is prolonged or sustained ischemia that causes irreversible damage to the heart muscle. We're going to look at three terms here that are related to sustained ischemia, myocardial infarction, and myocardial inflammation and necrosis. Starting at the top of this flow chart, we're going to look at what's called myocardial stunning. With sustained ischemia, we can experience stunned myocytes or myocardial stunning. This is a temporary loss. It's almost like they're stunned, a temporary loss of contractile function, and it can persist for hours to days, even after perfusion has been restored. The stunning can occur because of alterations in how electrolyte pumps are functioning, the presence of calcium. There might be toxic oxygen free radicals that are present. But in any case, myocardial stunning is characterized by a reduction in contraction, as already mentioned. There's also a reduction in conduction. So the heart's conduction system needs to function properly in order for the heart to contract. And this can contribute to heart failure, shock, and abnormal heart rhythm. So we know it's due to sustained ischemia, and it doesn't just occur because of ischemia to the heart. It can also occur after somebody's had central nervous system trauma or cardiovascular system surgery. Next up is a hibernating myocardium or hibernating myocytes, which can be caused by, as well, sustained ischemia. A hibernating myocardium refers to tissue that is persistently ischemic, and it undergoes a metabolic adaptation in order to survive, in order to prolong myocyte survival until perfusion can be restored. So it hibernates temporarily, hoping to survive. Restoring adequate perfusion to the myocardium, so there are different revascularization therapies that can be done in a medical environment, can help restore blood flow so that these hibernating myocytes don't die. Next up is myocardial remodeling. We're going to see myocardial remodeling occurring after a myocardial infarction, and it's also going to be occurring after inflammation and necrosis is evident. So those pathophysiological changes are evident. Myocardial remodeling can lead to hypertrophy or enlarging of myocytes as a response to these events, and it can cause loss of contractility. But we can really limit the degree of remodeling by rapidly restoring coronary flow. And also the use of drug therapy after somebody's had a myocardial infarction. So you don't need to write this down, but this would be the use of ACE inhibitors, beta blockers, statins. Somebody might need a pacemaker or some sort of ventricular assistive device. But in any case, making sure that care is taken immediately and then afterwards to prevent damage, or at least reduce damage. So acute mental stress can have an impact or can trigger a cardiac event, especially if somebody has some predisposition to heart issues, including atherosclerosis, a prior myocardial infarction, or poor left ventricular function, remembering that that left ventricle is so important in pumping blood to the entire body. So what sort of effects can acute mental stress have on our central nervous system and our autonomic nervous system? Well, it can increase catecholamines within the blood, so epinephrine, for example. It can increase our heart rate and increase our blood pressure. Much more demand on the heart. We can see a reduction in plasma volume, an increase in coronary constriction, so this is vasoconstriction of the coronary arteries. There can also be an increase in platelet activity. Some other effects that can be seen because of these physiologic responses to acute stress can be an increase in electrical instability. So the electrical supply to the heart that permits a contraction needs to be appropriate. Acute mental stress can lead to an increase in demand on the heart and a reduction in supply, blood supply to the heart, which is a problem. If we need more, but we're getting even less, you can see why that would be a problem. We know that ischemia can result from the variables that we're seeing here. Plaques can rupture, clots can form, and this can lead to a myocardial infarction. So if somebody who might have a predisposition, but everything is okay, and then acute mental stress can just exacerbate everything. The last thing I'd like to point out here is VF and VT. VF stands for ventricular fibrillation. This is the most serious heart rhythm irregularity. So it's an irregular heartbeat, and why it's the most serious is because the ventricles are pumping blood out of the heart. The left ventricle in particular is pumping blood to the rest of the body. So somebody with ventricular fibrillation, if it is not corrected fast, will end up with sudden cardiac death. The heart just stops. And then ventricular tachycardia is VT. This is where the ventricle is beating much faster, not necessarily irregular, but much faster than is considered normal. Also leading to sudden cardiac death if not addressed. Let's look at some of the complications that can occur following a myocardial infarction. Somebody that's had a myocardial infarction but survives it is more likely to have dysrhythmias, so abnormal heart rhythms. And that's because the conduction system, that nervous tissue component of the heart, if it lost blood supply and doesn't function properly, then it's not going to send the appropriate conduction throughout the heart. Remembering our conduction system shown in the image here. Aneurysms can form within the heart, so the heart wall itself can expand. Valves might not function properly, especially if there was any necrotic damage to the valves as a result of the heart attack. And you might remember the chordae tendineae here that's attaching those valves to the heart. Pericarditis, inflammation of the pericardium, is a common complication of a myocardial infarction. And this inflammation of the heart, which might not even be noticed until maybe a few days after a myocardial infarction, but somebody will complain of chest wall pain, so anterior chest wall pain that's worse when they try to take in a deep breath. And there isn't really a specific treatment for it to clear it up, but steroids can help reduce some of that inflammation and improve the person's symptoms. Heart failure and pulmonary edema, so swelling within the lungs, can also occur. And why does that occur? Well, we'll talk more about heart failure and pulmonary edema in later lectures, but just to give you an idea now, if the heart cannot properly pump out all of the blood, it can back up. And if it backs up, it can actually back up into the lungs, causing swelling or edema within the lungs where fluid just seeps out into the lung tissue. So those are complications relating to the heart itself, but there can also be systemic complications, including shock, which can affect various systems within the body. Embolisms can form if blood's moving more turbulently or maybe being pooled, or if there is a dislodged clot, can travel to other areas of the body. And then death can occur. Death usually occurs if the heart just stops functioning or if shock occurs. All right, let's put some of this together. If there's an imbalance between coronary supply and myocardial demand, we can be left with an oxygen deficit to the myocardiocytes that make up the heart muscle. If this deficit is less than 20 minutes long, it can be considered an ischemic attack. An ischemic attack can mean that the heart muscle doesn't respond properly to the electrical impulses sent to it, because remembering back to normal anatomy, in order for any muscle to contract, it first has to be stimulated by a nerve or by a nerve impulse. So an abnormal response can lead to an abnormal heart rhythm. Now, if this is affecting the ventricles, leading to what we talked about earlier, ventricular fibrillation, it can lead to sudden death. In other cases, it can impair the cardiac pumping and hopefully ends up getting resolved. Otherwise, it can lead to heart failure. Impaired cardiac pumping is also going to bring us back up to where we started, where we have a further imbalance between coronary supply and myocardial demand. Now, if the myocardial oxygen deficit is lasting greater than 20 minutes, so 20 minutes seems to be that in around magic number, we could have two potential general events occurring. One, there's an abnormal response to the electrical impulses, following the same pattern that we talked about before, or there can be a complete lack of response to electrical impulses. If we don't respond to it, it's not contracting, and failure to contract is going to impair cardiac pumping and lead to heart failure. On this slide, we're going to review for a moment an electrocardiograph, an ECG. You should have learned about this in normal anatomy. Here we have normal ECG deflections. What's happening here is these sensors are going to be picking up electrical information about the heart. And it's presumed that if the electrical signal is there, that the heart will follow with a contraction. And so I'm going to remind you of what these deflections represent so that clinically when they're read, they have meaning. The P wave indicates atrial depolarization, which is when the atria will then contract. So it depolarizes where the impulse is sent throughout the atria, it depolarizes and then contracts. The QRS wave, a little bit more complicated, is going to include the state where that atria is going to now repolarize, which will follow with relaxation. But also within the QRS wave, we have ventricular depolarization where the ventricles depolarize. So that's that electrical signal being spread throughout the ventricles. Then the ventricles will follow with a contraction. Now the T wave here is representing repolarization of the ventricles where they are starting to return to their resting state, and then the ventricles will respond by relaxing. Now that we know what a normal ECG would look like in terms of the deflections shown here, let's have a look at what changes we'll see when myocardial cells undergo ischemia and possibly an infarction. Cells that have experienced, ischemia become hypoxic, and they can distort the electrical signals that are measured across the myocardium, across the wall, during an ECG. Now, we know that some people with myocardial ischemia may only experience pain or angina when they are exerting themselves or when they exercise, because that's when the demand goes up for oxygen requirements for the heart. And we can't provide the heart with the oxygen that it needs during that time. And so if they're not exercising and you perform an ECG on them, it may come back as normal. Really, your only option to detect an issue in these cases is one, to actually do an ECG coincidentally when the patient is having an attack of angina, but in most cases you can't time that. And so instead what you'll do is an exercise stress test. And so we can see in this image here, there's a gentleman that's walking on a treadmill, and they'll get him to the point where his breathing starts to change and his heart rate picks up, and then the ECG will run. And that, if the patient is experiencing myocardial ischemia, should pick up those changes. There are two types of myocardial infarction. When coronary blood flow is interrupted for an extended period, we know that myocyte death and pathologically we can see necrosis, this can occur. And this results in a myocardial infarction. Pathologically, there are two major types of myocardial infarction: subendocardial and transmural. And this really has to do with the location. So in this simplified example here showing you the heart muscle, you can see the pericardium that surrounds it. And then this thick muscle here is your myocardium. And then the inner layer where blood comes into contact with when it moves through the heart is called the endocardium. Subendocardial region is really just in between this endocardium and the myocardium. So it would run right around here. The other type is transmural. So this would be where an infarction isn't just affecting this region like with subendocardial, but it's across the wall of the heart. So it's called transmural. Now, clinically, though, we can categorize myocardial infarctions as STEMI versus non-STEMI. You need to know what this stands for. STEMI stands for ST, shown here, ST elevation myocardial infarction. Non-STEMI stands for ST elevation, non-ST elevation myocardial infarction. So what does this mean? Well, when an ECG is done, there's a particular area called the ST segment, shown here, the ST segment. And when this segment is elevated, the person is said to have a STEMI, an ST elevation myocardial infarction. And so let's have a little bit more of a look at what we would specifically see on an ECG under certain circumstances where someone has experienced ischemia or an infarction. A transient ST segment depression and a T wave inversion, which we'll look at in a moment, are indicative of subendocardial ischemia, and these people will present with angina. So if we look over here, here is the ST segment depression. So it's depressed here compared to normal. And then T wave inversion means that instead of the T wave being running up in this direction, it's running down. And so here's an example of a non-STEMI, what we just spoke about with the subendocardial ischemia, and here is the subendocardial ischemia. Now let's have a look at ST elevation. ST segment elevation, you can see the entire segment here has been elevated, so much so that it's distorted. When this is evident on an ECG, it is indicative of transmural ischemia, so across the wall, and you can see a STEMI here. It's across the wall instead of just this one area. And this you would more commonly see associated with a myocardial infarction, as well as what we had spoken about earlier is the Prinzmetal angina. So the ST segment, this best reflects the electrical events occurring inside the ventricle. So I could say that another way and say that if there is ischemia in the ventricles of the heart, then it's going to likely affect the ST segment as viewed on an electrocardiogram. So it's either going to be depressed or it's going to be elevated. Okay, that is the end of today's lecture. Thank you so much for your time. Bye for now.